Okay, thank you, everybody. Good morning, good afternoon, and good evening. My name is Jessica Pullen, and I am the Knowledge Management, Communications, and Learning Officer for the TAN project at Nutrition International. Thank you for attending our webinar, Adapting NTEAM's Technical Assistance in Ethiopia to the Nutrition Challenges Posed by COVID-19. We are delighted to have you all here with us today. Before we begin, I'd like to go over some housekeeping. Please note that this webinar is being recorded and that the recording will be shared publicly within a few days' time. Please also feel free to introduce yourself in the chat box. It's always great to see who's participating and from where. Just be sure to set the to dialogue to all attendees and panelists so that everyone can see. Finally, please do feel free to post questions for the speakers in the chat box throughout the webinar, and we will take note of them for the Q&A session. Thank you. Next slide. I'd now like to introduce you to our moderator for the webinar, Nutrition International's TAN Project Director, Anne Babcock. Anne is a development professional with 16 years experience leading complex projects to successfully deliver results. She has held program management roles at Plan International in the UK and in Sierra Leone, where she not only managed multi-country girls' education projects funded by UK aid, as well as corporate donors, but also oversaw consortia programming on education and Ebola response. She has worked with international HIV and AIDS networks, where she coordinated communication projects in East and Southern Africa and supported FCDO with knowledge management. Before moving into the project director role at Nutrition International, Anne served as TAN Senior Program Manager, responsible for providing supervision and coaching to TAN regional staff and senior consultants, as well as overseeing planning and implementation of country technical assistance. Anne holds a postgraduate degree in international development and anthropology from the London School of Economics and Political Science. Thanks, Anne.
Thank you, Jess. Hope you can all hear and see me. Good morning, good afternoon, and good evening, everyone. It's good to be together. Welcome to this, our second webinar on adapting Nutrition International NTEAM technical assistance to the nutrition challenges posed by COVID-19. Now, this is the first of two webinars. The first was held 2 weeks ago about technical assistance in Bangladesh. So today we will be hearing about how technical assistance in support of the Ethiopian government has responded to the global COVID-19 pandemic. Now, at Nutrition International, we know that nutrition must be integrated into every phase of the COVID-19 pandemic response. The immediate response, the resilience building, and the recovery. Certainly the right nutrition at the right time can mean the difference between life and death for the most vulnerable, including women and children. So without coordinated action, a second, potentially more devastating crisis of malnutrition and hunger will follow. Therefore, the purpose of our gathering today is three things. There may be others, but I will highlight three. We're here to learn about incorporating nutrition considerations into responses to the COVID-19 pandemic from the experience of the government of Ethiopia, to explore how Nutrition International's technical assistance in Ethiopia rapidly adapted to support COVID-19 response planning, and lastly, to provide an opportunity for participants to ask questions about and share their own experience with adapting nutrition-related work in response to COVID-19. So by way of an overview of the webinar structure, it will consist of opening remarks by NI's esteemed Regional Director for Africa, Dr. Richard Pendame, followed by a 35-minute presentation by three speakers, after which we will do our best to reserve a solid 40 minutes for question and answers and experience sharing. And we'll talk you through some of the ground rules for that later. This morning or this afternoon, our speakers include Dr. Ferew Lemma, Senior Nutrition Advisor at the Ministry of Health and Sun Focal Point, Ethiopia. Dr. Sisay Sinamo, Nutrition International's NTEAM TA provider, embedded in the Federal Program Delivery Unit in the Ministry of Health in Ethiopia. And Dr. Amare Deribew, Nutrition International Country Director for Ethiopia. I am very fortunate to be the one to moderate this panel of committed, passionate, and exceptionally skilled and experienced individuals. So that's it. That's the order of operations for the next hour and a half or so. So let's jump in. By way of background, through NTEAM, Nutrition International is pleased to support a number of technical assistance assignments in Ethiopia over the life of the UK aid-supported TAN project. Due to demand from countries, notably some focal points, NTEAM have been increasing the breadth, depth, and scale of TA on a number of things, including costing and financial tracking globally. We are privileged to have experience doing so in Ethiopia to date, and beginning a piece of technical assistance with the Ministry of Health in support of nutrition costing and enabling nutrition policy and enabling the nutrition policy and planning environment. And where we are supporting integration of the Seqota Declaration expansion and scale-up plan into food and nutrition investment cases. So we must meet again about this valuable work, but today we're going to cover and hear about technical assistance in support of coordination for effective multi-sectoral nutrition response through the 15-year Seqota Declaration strategy to end child undernutrition in all its forms by 2030. It's all connected, but that's going to be our focus today. Before we hear from our three fantastic speakers, I will hand over to my director in Africa, Dr. Pendame, who will provide opening remarks and get us warmed up. Now, as indicated, Dr. Richard Pendame is the Regional Director for Nutrition International Africa. He is a medical doctor, a public health specialist, a manager and a leader with over 25 years of work experience in clinical medicine, management of health systems, and public health programs, public policy formulation in health and nutrition sectors. He holds a master's degree in public health, epidemiology and health systems management from the Bloomberg School of Public Health of Johns Hopkins University, and a postgraduate certificate in health management from Birmingham University in the UK. Also a Bachelor of Medicine and Bachelor of Surgery, jointly awarded by Universities of London and Malawi. Richard, it's great to have you with us today. The floor is yours.
Thank you, Anne. On behalf of the Nutrition International Executive Management Committee, and indeed on my own behalf, it is my pleasure to welcome you all to this webinar session. Madam Moderator, allow me to highlight why this session is important to Nutrition International, as well as to the Nutrition International Africa region. The Nutrition Technical Assistance Mechanism, abbreviated as NTEAM business model, came into being almost 7 years ago, after recognizing the need by governments, multi-sector organizations, and nutrition partners for quality, timely, and coordinated expert technical assistance to governments, to multilateral organizations, and nutrition partners. It is our belief that such technical assistance would go a long way in developing institutions' capacity to plan, to coordinate, to mobilize resources, to implement, to monitor, and evaluate multi-sectoral nutrition programs, thereby supporting the scale-up of nutrition services for the most vulnerable. Since the start of the NTEAM, NI has provided TA support to 12 SAN countries in the Africa region. In addition, NI has provided support to regional institutions such as the African Development Bank and the East and Central Africa Health Community. It is therefore pleasing that this webinar has been organized to share lessons learned in adaptation of NTEAM in the government of Ethiopia to address the challenges of our time, which is the COVID pandemic.
Great, thank you very much, Dr. Pendame. So without further ado, let's get started. It's a privilege to introduce you to Dr. Ferew Lemma, Senior Nutrition Advisor for the Ministry of Health and Sun Focal Point for Ethiopia. Now, Dr. Ferew has a wealth of impressive experience, which really makes it a privilege indeed to hear from him today. He's a public health physician who holds a PhD in public health nutrition from the London School of Hygiene and Tropical Medicine, as well as being the Sun Focal Point since 2010. Dr. Ferew has been serving as Senior Nutrition Advisor to the Ministry of Health in Ethiopia. And between 2014 and 2018, he also served as an advisor to the former First Lady of Ethiopia. Previous roles he has held include Deputy Head of the Regional Health Bureau, Assistant Professor of Nutrition and Planning and Program Officer at Jimmy University, as well as Senior Research Fellow at London South Bank University. Dr. Ferew was previously co-chair and is presently a member of the Global Nutrition Report Executive Committee and Steering Group. He is an active member of the Council for Research and Technical Advice on Acute Malnutrition and a council member for the Global Alliance of Improved Nutrition Partnership, GAIN. Dr. Ferew has published articles in various journals on topics such as nutrition, health service delivery, health professionals capacity building, finance tracking for nutrition, monitoring, evaluation, and mental health. Dr. Ferew will share with us now about what COVID-19 looks like in Ethiopia at present and from March to onwards, how it's affecting the country and the nutritional status of vulnerable children, men and women. Dr. Ferew, it's a pleasure to have you with us today. The floor is yours.
Thank you, Anne. Hello, good morning, good afternoon, and good evening, everybody. This is Ferew. I'll be providing the Ethiopian COVID-19 update, as well as what we have been doing and where we are now. And the next slide, you'd see the contents of my presentation, particularly dealing with the preparedness and response, what are our challenges and what we plan to do in going forward. The next slide will show you the situation of COVID in Ethiopia since we found the first case in March 13 from a travel agent. Till the end of March, we only had those who had contact history or those who only traveled. But early May, we started looking at community cases. And in June, the community cluster cases started increasing. And you see from June onwards, we had July onwards, we have seen quite a 70% of our cases, which we have now in Ethiopia. So the whole situation started about 8 months ago. In the next slide, you'd see the most recent cases distribution in terms of daily. So you see that the positivity rate in red lines indicates ranges from 4% to 14%, while we had a high testing rate in early September, end of August and September. We had a combat or a campaign, and we tested around 20,000, but and nowadays we are testing about 5,000. Overall in Ethiopia, the positivity rate is 6 to 7% of all those tested. We have tested 1.6 million. Our recovery rate is around 65,000, it is 63%. And the mortality rate, which 1,700 people have passed away, is about 1.5%. So what was done? In the next slide, you'll see what the preparedness and response measures were. The first thing that was done immediately after the first case was diagnosed was the Public Health Emergency Operations Center at our Ethiopian Public Health Institute was initiated and started work at federal as well as regional level throughout the country. After that, in addition, there was a high leadership led by the Deputy Prime Minister, which was managing, looking at cross-sectoral as well as vertical and horizontal actions being taken. And most of these started with a state of emergency with restrictions in various actions which we'll see. There were also actions being started in terms of risk communication and community engagement, as well as the social distancing, face masks, and hygiene and water and sanitation activities. Then pharmaceutical interventions were being done. Throughout this period of 8 to 9 months, also the testing and the treatment and centers as well as capacity building has been going on. If you look at what were the actual state of emergency actions, the next slide shows that some of the activities that were for 6 months stated were no more gathering individuals for more than 4 people. There was a reduction of public transports by 50%, as well as gatherings, including social and religious gatherings, were prohibited. Schools and universities, as well as businesses like restaurants and bars, were closed. And government workers are also asked to work from home, alternatively, based on the situation. So the government stringency indexes were quite very high until September, for 6 months. It went down to 77, and it's currently at 65 level in terms of closures, as well as the social and gatherings, as well as transportation. So overall, we had the next slide, and it tells you about what we are doing in terms of testing. As I said, when we started testing, we used to send it to South Africa for quite a couple of weeks. But after that, currently we have reached up to 64 sites throughout the country with around over 80 testing machines. However, we have also now started the production of a test kit at country level. So we'll soon be going back to testing 20,000 tests, doing 20,000 tests per day. So what has happened in terms of the nutrition and other essential health services? The next slide shows you that some of the impact, particularly in terms of essential health and nutrition services, was quite a disruption, because a lot of our health facilities, starting from our health extension workers, health posts, were closed. And then essential service commodities were also very lacking. The issue of the personal protection equipment, as well as the IPC, were also lacking. So service delivery was quite low at the beginning of March and April. There was also emergencies or inabilities to do social behavior change communications, as well as build capacity of health extension workers, as well as our health facility, primary healthcare units, and a lot of issues with the transportation being reduced or restricted. There was a high cost in terms of delivering the services. In terms of nutrition, I think the main thing was the high price increase in terms of staple foods, as well as nutrient-dense foods like fruits and vegetables, as well in transportation and labor costs in terms of transporting through the value chain, the foods and the nutrient-dense foods and staple diets was quite high. So the price increase was quite a challenge for most. But there were also misconceptions in terms of animals for food consumption. Fruits and vegetables were quite being variously approached by different community groups. So what was done in the next slide, you'd see some of the general plan we had in terms of, we had a plan for food and nutrition preparedness and response through the COVID time, particularly focusing on very highly food insecure areas, as well as with which we call the social protection program we have in Ethiopia, we call PSMP, Productive Safety Net Program. Those were highly affected because it covers around 8 million people in food insecure districts. So these were done in terms of the various level activities through these interventions, including food and nutrition support, as well as in terms of mobilizing communities and behavior change and others. But my colleague, Dr. Sisay, would go through these in detail. And then in the next slide, we see what in general our challenges were. The challenges after 6 months, because of was lifting of restrictions after 6 months due to, as I said, the social economic impacts, as well as some political negative impacts. The restrictions were raised, and there is quite a widespread increase of positivity rates throughout the country, particularly the capital city in Addis Ababa. In addition, there are also competing priorities in terms of, we had emergency floods, we had desert locusts, which is affecting the agricultural produce, but also some security issues within the country. And also there is quite still the essential health and nutrition services are still compromised. Those are our challenges in terms of giving services, particularly to health and nutrition services. And the next slide shows you what we plan to do as moving forward. So most of the activities are mainstreaming and integration of the essential health and nutrition services within the COVID response, but also have specific targeted activities in specific areas where the capitals, including Addis Ababa and the regional capitals, also accelerate our testing because we are having a production of the test kits locally, and also the treatment centers and isolation and quarantine centers will planning to be expanded. In terms of what we need as further support, the next slide shows that our main areas of focus are for resource for pharmaceutical logistics and technical assistance to do the prevention and community-based activities, the media, communication, continuous engagement with community, but also we want to share through such kind of webinars, information exchange, as well as experiences from neighboring countries, as well as global colleagues, so that we could learn and the good experiences that is happening throughout the world, and also work jointly with our partners, research institutes, to have a better monitoring and evaluation to improve our quality. All these are, as I say, need resources, and I hope we'll hear from you. Thank you.
Thank you, Dr. Ferew, for sharing such rich information about the COVID-19 situation in Ethiopia, including testing information, trends, the preparedness and response measures, impacts and challenges in Ethiopia to date, especially on essential health and nutrition services and availability of nutritious foods, and some of the things that you're doing and that the government is doing to mitigate against that and those challenges. Certainly, it was notable to me how multi-sectoral sort of coordination is key in responding to those challenges. Now, building off of Dr. Ferew's presentation, I'd like to introduce you to Dr. Sisay Sinamo, Nutrition International's NTEAM TA provider embedded in the Federal Program Delivery Unit at the Ministry of Health. He's going to share with us about what the TA has actually accomplished and how it has adapted and changed in order to continue to strengthen nutrition coordination and improve undernutrition during the COVID-19 pandemic. And this is no small order. Dr. Sisay has been a TA provider in Ethiopia since 2017. As the Senior Program Manager at the Federal Program Delivery Unit, Dr. Sisay provides technical and administrative leadership for the federal and 2 regional program delivery units, where 9 sector ministries implement the Seqota Declaration innovation phase. Dr. Sisay has a doctorate in medicine from Addis Ababa University Medical Faculty and a Master's of Public Health degree and PhD in Public Health Nutrition from the University of Western Cape in South Africa. He has over 19 years international experience in the field of developmental and emergency health and nutrition, multi-country programs and program leadership. Previously, he has coordinated and provided technical support for 26 African country nutrition programs and has also provided nutrition leadership and technical guidance in emergency and development contexts in 9 East African countries for over 7 years. Dr. Sisay will be sharing how his technical assistance support is helping with successful delivery of the Seqota Declaration implementation phase and what adaptations and changes have had to take place in order to continue to strengthen nutrition coordination and improve undernutrition during the pandemic. Dr. Sisay, it brings me great pleasure to welcome you to the webinar today. You have the floor. Please go ahead.
Thank you so much, Anne, for a kind introduction. Good morning, good afternoon, and good evening. Sorry, because of the bandwidth, I may not be using a camera, but I will be presenting with a mic. First of all, I would like also to thank the NTEAM and FID for giving me the opportunity to provide this technical assistance to the government of Ethiopia. So the technical assistance is entitled Technical Assistance to Support Seqota Declaration Implementation in Ethiopia. And the objective of the TA is to provide technical assistance to support successful delivery of the Seqota Declaration implementation plan, which is developed by the government of Ethiopia. The expected deliverables of this TA are to provide technical guidance to the Federal Ministry of Health, Sun Focal Point, Program Delivery Unit staff, and other stakeholder staff for effective design, implementation, and monitoring of the Seqota Declaration, and support development and implementation of framework to facilitate multi-sectoral coordination and result-oriented engagement. And the last expected deliverable of this TA is to facilitate institutionalization of systems for continuous documentation, learning, and adoption of good practices during the Seqota Declaration implementation. Next slide, please. So in this slide, I will give a little bit more information on Seqota Declaration so that you will be able to understand a bit deeper what this TA was doing to achieve the expected deliverables, and also how this TA has been impacted with COVID-19, and also how we tried to mitigate the impact of COVID-19. The Seqota Declaration 15 years implementation strategy with defined innovation to be tested is summarized, as you can see in the slide. And the Seqota Declaration is a government commitment to end stunting in Ethiopia among children under 2 years by 2030. And this commitment was unveiled in July 2015. And the government has committed to preventing an additional over 7.85 million children from stunting and enable them to grow to their full potential. As you can see, the 15 years roadmap, is divided into 3 phases. The first phase is called the innovation phase, which extends from 2016 to 2020, which we call it a learning by doing phase. And the second phase is the expansion phase, which we are now making preparation to reach more high stunting, prevalent, vulnerable communities in other part of the innovation phase waradas. In the last part, which we will start by 2016, will be the national scale-up phase, which will build up the learning that will be generated from the innovation and the expansion phase. Currently, we are implementing the innovation phase in 40 waradas, which is district, in 2 regions called Amare and Tigray regional state in the northern part of the country. The total population of the current operational area is over 4 million people, of whom they live in over 954 households. And currently we are operating to reach over 200,000 children under 2 and over 135,000 pregnant lactating women. When we look at the stunting prevalence in this innovation phase waradas, the prevalence is 48%, which is the average, which is very high compared to the national average of 37%, and the global stunting prevalence threshold to consider it is critical. So in some part of these districts, even the stunting prevalence goes as high as 55%. So that's why the government has prioritized the innovation phase in these two regions and 40 waradas where we are now testing the innovation phase. In terms of implementation, 9 sector ministries, namely health, agriculture, water, irrigation, energy, education, labor and social affairs, women and children affairs, transport, finance, and culture and tourism work together. And these sectors overseen by His Excellency, the Deputy Prime Minister of Ethiopia. And at regional level, the similar sectors are also overseen by the highest government authorities, who are the Excellencies, the regional presidents, to deliver the responsibilities indicated in the 15 years implementation strategy, and specifically for the innovation phase. To mention in detail what are the innovation phase, because this will enable us to understand better how COVID-19 really affected the SD innovation phase implementation. I will describe a little bit deeper in terms of the 6 innovations. So the first innovation is the program delivery unit. The program delivery unit, we have 3 program delivery units, 1 at federal and 2 regional level. They are established with financial support of the Big Win Philanthropy to driving a multi-sectoral response to address stunting in Ethiopia. The core functions of the 3 Seqota program delivery units include strategic management, coordinating the declaration, specifically providing secretarial support to existing interministerial coordination bodies, and also technical committees for the design, implementation, tracking of nutrition smart programs. The third core function is monitoring and performance management. And the fourth one is engaging with senior leadership and also communicating results and accountability. As a program delivery unit, which I coordinate the federal program delivery unit, we have 5 multi-sectoral team staff. At regional level, in the 2 regions, each have 11 staff, and also in the 40 waradas, we have the warada coordinators who also work with the warada administrators to coordinate all the sectors. The second innovation is a community lab. A community lab is a powerful multi-sectoral platform that convenes a diverse set of stakeholders in the community to work collaboratively in identifying key challenges and designing and implementing solutions to address complex and multidimensional problems such as stunting. The community labs are mechanisms for testing innovative solutions before scaling up to the successful ones. To do so, we have a tool, what we call it the LRI methodology, which is learn, reflect, implement, or innovate, which is a simple 3-step process for identifying and prioritizing nutrition-related problems in their communities and driving potential solutions and testing those solutions before scaling up the successful one. Currently, the communities have identified various innovative solutions at the community level, and some of the successful ones are being scaled up in the innovation phase waradas. The third innovation that is being tested is the first 1,000 days plus public movement. The first 1,000 days public movement is a social mobilization and SBCC movement that aims to facilitate the adoption of good nutrition practices by women and children, especially during the 2 times of period. The first one is the first 1,000 days between a woman's pregnancy and her child's 2nd birthday, which is a critical window of opportunity when the foundation for optimal health and development across the life cycles are established. And the second opportunity during the first 1,000 days plus public movement is the adolescent period, which addresses issues related with adolescent girls and nutrition education. Informed by the Seqota Declaration Baseline Survey, which NTEAM has also made a financial contribution, the first 1,000 days plus public movement utilizes the social ecological model in addressing the identified gaps in the key nutrition knowledge, attitude, practice at individual, household, and community level in order to end stunting in children among children under 2 years of age by 2013. The fourth innovation is what we call is the ITEC, Agricultural Innovation and Technology Centers. The Agricultural Innovation Technology Centers are medium-scale, economically self-sustainable farms that act as a regional mechanism for agricultural development extension, research, capacity building, and overall transformation of the agriculture center. The ITEC farm also serves as a path for the integrated introduction and demonstration of innovation and technologies for horticulture, crop farming, and livestock production that improves the productivity of smallholder farmers. It is designed for 20 hectares of ITEC farm, which are now completed for one of the districts called West Balasa in Amare region. And also preparation is being made for another warada called Tankwa Bergale in Tigray regional state. Along the ITEC centers, we also are introducing the Bank of Water Technology Solutions with a tier provider called Cultivate, financed by Big Win Philanthropy, with the aim of introducing and piloting various water technologies related to water management, storage, quality, transportation, and monitoring, and also utilization of water-efficient technologies for irrigation. The fifth innovation is a costed warada-based plan, which is a costed warada-based multi-sectoral nutrition investment plan. To operationalize a truly multi-sectoral response, a costed warada-based multi-sectoral nutrition investment plan is developed as part of the innovation phase to address a limited horizontal intersectoral coordination mechanisms at warada level, and also insufficient funding for priority nutrition interventions. In our case, during the innovation phase, we adopted what we call it a 3-1 approach principle: one goal, one plan, and one monitoring and evaluation system in the development of this costed warada-based multi-sectoral nutrition investment plan. Each plan consolidates the nutrition-specific, nutrition-sensitive, and infrastructure interventions, and the resources are allocated by the government ministries and development partners for their implementation to address a common goal of promoting mutual accountability and ensuring results. The costed plans are intended to serve as a means to promoting increased awareness of ownership at warada level and contribute to the nutrition investment by the government and also sectors. In the past years, this planning process has enabled the government to allocate more and more resources for nutrition. For instance, a year before, the government has allocated from the federal treasury around 16 million USD, and the regional government has allocated 13.9 million USD. And this fiscal year, which started, this Ethiopian fiscal year, which started in July 2020, both federal and regional governments had already made a commitment over $25 million for Seqota Declaration Innovation Phase implementation. So when this is added up with stakeholders and donors' contribution, we will be able to reach more communities in the Seqota Declaration waradas. And also this will be an opportunity to generate learning for the expansion phase. The final innovation is the data revolution. The data revolution goal is to develop and implement a culture of data-driven decision-making by establishing a robust multi-sectoral data management system to collect a high-quality data that will inform decision-making and interventions targeting and also ultimately leading to reduced childhood stunting. So the primary activities in the data revolution is to build robust electronic data system to capture routine administrative data, to develop lean supplementary reporting system in selected geographies, to design and evaluate studies, to analyze monitoring and evaluation data, to advocate for building capacity for sectoral focal persons, and also map Seqota Declaration implementing stakeholders and track government and development partners' financial allocation and expenditure. So in the past years, we have been able to achieve to roll out the Unified Nutrition Information System for Ethiopia, for monitoring tools for multisectoral nutrition coordination, and also to track multisectoral nutrition data from lower level. Now this has reached to a number of waradas in the Seqota Declaration areas. We have been able also to introduce YASMI technology solutions to improve data accessibility in areas where there is no access to electricity and poor internet connectivity. This is also financed by the Bill and Melinda Gates Foundation. We have also conducted an informed decision-making, especially on financial resources. We have done the online nutrition resource tracking and partnership management with funding from NTEAM, and we have conducted the financial allocation and the expenditure tracking for the past 2 years, and of course the last year also we are completing the last year report. Is going to be 3 years for the Seqota Declaration investment. So these are all the activities that we are undertaking, and in the middle of this, you know, the COVID outbreak emerged, and it has affected a number of things that we are undertaking. So we will look at now what are the real impacts of COVID on the Seqota Declaration innovation phase implementation. Next slide, please. So as Dr. Ferew indicated, the first impact on the movement restriction. As I have said, a number of innovative interventions were being piloted, tested, but all of a sudden when COVID-19 comes, the movement restriction really hindered us in terms of on-the-site follow-up of the activities being implemented on the ground, as well as also supervision of all the activities being undertaken through a multisectoral platform in the 40 waradas. So it also restricted us the joint multisectoral supervision, as well as also the learning journeys that we were conducting in Seqota Declaration waradas. The other impact, which also Dr. Ferew has mentioned, was the lack of the right information and misconception about the COVID-19 transmission. That really resulted into slowdown or discontinuation of some of services as well as ongoing activities. In terms of misinformation and misconception, at the start of COVID-19, people were really didn't continue like consuming fresh fruits and vegetables. And also there was a number of misinformation about the various ways of COVID transmission that really affected especially the first 1,000 days public movement SPCC interventions that the declaration has made a number of progresses. The other activities that were really discontinued was the service in terms of ongoing activities, includes like the antenatal care, nutrition services, institutional delivery, community-based activities, including nutritional promotion and screening, as well as also some of the infrastructure works that were undertaken by the Seqota Declaration waradas, including water, irrigation, farmers training centers for nutrition corner, and also other activities. The third impact was on the coordination. Coordination meetings were slowed down due to prioritization of COVID-19, which results into postponement of annual planning and review meetings. As I mentioned earlier, Seqota Declaration is being led by their excellencies, their ministers, the regional presidents, zonal, warada, Kabali administrators, and bureau heads. But when COVID comes, you know, those very strong coordination meetings could not be sustained due to reprioritization of COVID-19 response. As a result, like the high-level forums that are being conducted at the national level, the interministerial reading committees that the excellencies were conducting, as well as also the regional level coordinating meetings led by their excellencies, the regional presidents. The zonal and Warada level coordination meetings have really suffered a lot and slowed down. Another impact through the coordination mechanism was in terms of the delay in budget commitment that was supposed to be allocated for the Seqota Declaration. Specifically, to mention one example here is the African Development Bank commitment, where we have the government have secured around 38 million USD for Seqota Declaration Innovation Phase implementation, which the bank board was supposed to approve in April 2020. But when COVID comes, that approval has been extended and we are still yet to get approval, and currently we have given a time for the approval to be February 2021. So we have really, the innovation phase has really also suffered from the, in terms of the budget commitment. The fourth one is in terms of the budget cut of the programs for the PDO ongoing activities. In the past 2 years, we used to get a huge amount of budget from the SDG allocation, but due to COVID, now this allocation has significantly reduced in terms of for the PDO capacity building and support. And finally, the market price escalation of commodities and logistics to sustain the planned activities, also one of the bigger impact that affected the innovation phase implementation in this TA, specifically through the agricultural interventions like the inputs, the seeds, seedlings, and poultry. For construction inputs like the cement price has really gone up, the irons and others. And even for the UNIS implementation, for the data revolution, the doubling of the computer's price and also other electronic equipment has been really affected the innovation phase interventions. Next slide, please. So what did we do as a TA provider to respond to the impact of COVID on the Seqota Declaration innovation phase implementation? We have divided the response into three categories. One is for the program delivery unit implementation, and also the other is the work that we did with the ministry, which I will be speaking on the next slide. And also the final one is in terms of multi-sectoral coordination. For the program delivery unit, when we realized the COVID impact, we have developed a PDU COVID-19 response and impact mitigation plan. This plan consists of the potential impacts of COVID-19 on the Seqota Declaration target population in geographic areas, and also what are the COVID-19 response and impact mitigation interventions on the staff, on the supporting waradas, on the warada coordinators, and also ensuring that the service continuity for the target population, and also the COVID-19 responsive actions in terms of the field visits, remote support, follow-up, as well as also especially for the Addis-based staff in terms of working from home. So once we developed this plan, we also communicated to the regional PDUs, we oriented them, as well as also the regional PDUs did similar orientation and communication for the Warada coordinators who are in charge of the Seqota Declaration interventions at the district level. The second one is in terms of, in order to fast track implementation of planned activities and also monitor closely the impact of COVID on the activities implementation, we developed a PDU weekly reporting tool to monitor the progresses and challenges, including the phone follow-up. So this will really enabled us to ensure that the amount of funding which I mentioned earlier transferred is liquidated in a timely manner, as well as also to timely identify the challenges that number of activities, whether they are progressing in a timely manner or not, and also make course corrective actions. After 2 months of implementation, we conducted a rapid assessment of the effect of COVID-19 on the PDU's human resource functioning and also SD innovation phase implementation. So based on the assessment, we've identified that a number of issues that are less affected by COVID, and also other issues that are most affected by COVID. So that has really enabled us to revise the COVID-19 response and impact mitigation plan, which I have mentioned earlier, and also readjust the action plans, including the frequency of monitoring, and also make more adjustments in terms of how we can provide support from federal and also regional PDU level. We also facilitated the revision of the PDU's 2012 April to June plan, because once we realized the effect and also which activities were more affected and which are less affected, we also made an adjustment on the plan. And especially for the development funded projects, we also made major revisions to fit into the context and make them COVID responsive. One good example is the work that we have done with SUN UNOPS, Seqota Declaration Capacity Building Project, where we had a large emphasis on the SBCC through training, meetings, as well as also people were need to gather in terms of capacity building. But considering the effect of COVID and also the restriction of meetings, we have made a number of adjustments so that it can be repurposed into mass media messaging, documentation, as well as also address the issues that we faced really on the market price because of the escalation of market price for the electronic equipment. And finally, in terms of the program delivery units, we engaged in the public communication and information sharing. So we used regional medias to disseminate nutrition information, which is also COVID sensitive. And also we shared various COVID-19 publications and global recommendations to the PDU team members. Next, please. So the other response of this TA to address the impact of COVID-19 was the support that we provided for the Ministry of Health. We have coordinated the write-up of the programmatic guidance on reproductive, maternal, newborn, child, adolescent, and youth health and nutrition services in the context of COVID-19. A number of directives has been given ahead of this for the respective regional health bureaus as well as health facilities, but there was no any programmatic guidance that was developed to facilitate those directives. So as a TA provider, I coordinated the write-up of this programmatic guidance to serve in the context of COVID, and also that has been really an important tool to support the health facilities in terms of addressing all these issues that they provide services. Another also technical support provided for the ministry is to provide support in the development of technical guidance and key message for nutrition in the context of COVID-19 response. So this is nutrition service delivery guidance to the health facilities, including the IYCF messaging, nutritional screening, and also how to do the growth monitoring, and also the other messaging on SAM and MAM response in the context of COVID. The last one is for multisectoral coordination. In terms of multisectoral coordination, we provided technical support in the development of a multisectoral food and nutrition response plan in the context of COVID. As you know, when COVID-19 pandemic happens globally, one of the fear was an increased number of people who would be food insecure. So to address that, we have developed the multisectoral food and nutrition response plan, considering the 8 million people under the PSNP, nearly 500,000 people on SAM, as well as also over 3 million people MAM, and also considering the urban PSNP and also those people who have special needs, as well as also people who could be affected outside of the PSNP program. PSNP is a program, a productive safety net program, which is the biggest productive safety net program, even among the biggest in Africa. Another support in terms of multi-sectoral coordination is jointly with the Ethiopian Nutrition Leaders Network. We led a series of webinars to provide orientation on the COVID-19 for nutrition professionals and also nutrition network members in Ethiopia. These members work in various organizations, including government, UN, academia, NGO, as well as private sectors. And the training and the webinar sessions enabled them to understand better COVID-19 and also how the government is responding, including the government directives, the government guidelines, the government messaging tools, and they will be able also to provide services in their organizations, and also how they can also better contribute in COVID-19 response. And finally, as a Seqota Declaration, we work we coordinate a number of sectors. So we have been able to mobilize the multi-sectoral Seqota Declaration implementing sectors at federal and regional level to conduct supportive supervisions, to provide on-the-site support and ensure service continuity and also activities implementation in the context of COVID. In this regard, we have been able to conduct two learning journeys. We call them learning journeys, which is like kind of a supportive supervision, but it has also a reflection component in May 2020 and October 2020. And also following the field visit, we have been able to organize the annual review meeting at regional level in October, where regional leadership, sector heads, implementing partners, and also Warada heads and also Warada coordinators participated to review the program in the context of COVID-19. So these are the TA responses that we provided. I think it will give you some idea of how the NTEAM in the Seqota Declaration has enabled to address the challenges of COVID-19 in Ethiopia. I thank you. Over to you, Anne.
Thank you very much, Dr. Sisay. Indeed, that was a really clear presentation about the defined innovations of the Seqota Declaration implementation strategy and how technical assistance provision with the Federal Ministry of Health has been affected by, but is also responding to and adapting in light of COVID-19 to realize its objectives. So thank you very much. I see there's lots of questions that have come up in the chat box that we want to make sure that we get to. But before we do, I want to give a few minutes to Nutrition International in Ethiopia to talk about our programming there and how we've adapted and how we're responding in light of the challenges presented by COVID-19. Dr. Amare Deribew is not available. I suspect he's having internet problems. Therefore, I will hand over to our Deputy Country Director, Mr. Girma Mamo. Mr. Girma, the floor is yours.
Hi, Anne, everyone. Good afternoon, good morning. Can you hear me?
Yes, we can hear you loud and clear.
Good. So thank you, Dr. Sisay, Dr. Ferew. I will be continuing from for the COVID response. The Minister of Health has provided a directive. So as everyone panicked for programming and a lot of responses has been tried, but what we have done at first was to look at the government response and the directive. With that, NI has first provided a framework, a guideline to successfully adapt and effectively deliver programs during COVID-19. So the policy mapping we have in the landscape analysis, we have found Minister of Health's guideline as a fundamental tool to help us shape and adapt NI programs in Ethiopia. So with that, in Ethiopia, NI programs are integrated. Next slide. We have maternal newborn health and the nutrition, vitamin A supplementation, zinc and ORS for the hair management, adolescent health and the nutrition. These are the health system based, and we have also food system programs like universal solidarization and the food fortification program. And we do have these cross-cutting interventions done, like Dr. Sisay's work. We do have advocacy and capacity building, advocacy and communication, capacity building interventions. So what we have done in the adaptation, what we call nutrition response plan. Our nutrition response plan is quite informed from landscape analysis, government response plan, and we have an understanding and experience that nutrition is usually pushed away or disadvantaged whenever the health system has a pressure, or be it budget or programming. So we kind of intentionally looked at the effect of COVID-19 and the possible effect of adaptation on nutrition. So we did a very good meticulous design, what we call the nutrition response plan. It is intentionally with a goal of like improving or mitigating COVID impact on nutrition and improve nutrition delivery during COVID. Next slide. So what some of the activities are really impacted by COVID, like our program, particularly the adolescent nutrition health program, which is run in school, implemented in school, interrupted because school is closed down. There are a lot of effect on solidarization program. Our brand, our what we call our main approach, collaborative quality improvement, which needs teamwork, gathering, learning session, all are halted because of COVID. So we need to adapt our programs. So what we did was we have about 9 TAs at a lower level. So after adapting this nutrition response plan, our TAs cascaded the nutrition response plan and aligned the NIS intervention, NIS strategy with government response plan. So these TAs, our extenders, provided essential and critical support warada at a zone and at a facility level. By doing so, we able to deliver most of the programs, particularly vitamin A supplementation, iron folic acid supplementation for pregnant women, zinc and ORS for diarrhea management. But unfortunately, adolescent programming was a bit complex and could not be implemented for supply and lack of platform. Next slide. So with universal solidarization, what we did was we have made a supervision in central iodization facilities, salt production areas, and we have developed a recommendation to the government, and they shared our recommendation to stock potassium iodate and the raw salt in central iodization areas. Fortunately, most of our Ethiopian central iodization areas have stock more than 3 months, which is somehow a low risk to the program. However, in terms of effectively implementing regulation, we have budget support to the regulatory agency called Ethiopian Food Drug Administration Authority. Then with that, I think if they effectively programmed and have able to maintain solidarization at household and retailer level as much as 70%, which is a success to us. In terms of food fortification, our TS has been made available, but because of these working from home policies, there are some ups and downs to deliver, like technical support capacity building was limited. Next slide.
Speaker, thank you, Mr. Girma. Just 1 more minute, okay?
Yeah. So eventually what we have done is, particularly during this COVID effect in the first 3 or 4 months, we have been quite engaged in coordination platforms at national, at local levels, at different programs with partners. So our TA extended our country office team has been providing quality assurance in programs, protections for. We made a budget support for Minister of Health at lower level to really effectively program and implement supervision, social mobilization activities. We have worked with multiple coordination and advocacy platforms to able to program and deliver nutrition services during this difficult time. This all from my side. Thank you.
Fantastic. Thank you very, very much, Girma, for filling in and for sharing with us the experience of Nutrition International projects and programs and adapting to COVID-19. It's really nice to root what Dr. Ferew and subsequently Dr. Sisay said in some realities on the ground in terms of Nutrition International's programming. So thank you very, very much indeed. I'm so pleased that we have a little bit of time left for questions. There's a lot that have come through. So I will just lay out some of the ground rules. I think you've already, most of you have added a lot of questions in the chat box already. If you have more questions, please ask them in the chat box. And please state which panelist you would like to respond to your question if relevant. I'll read out the questions and direct them to the different panelists accordingly. We apologize if we're unable to get to everyone's question. And also to say, I think we're running short on time for experience sharing. So because there seems to be so many questions, we will focus on that before we close today. So the virtual floor is open for questions. And I am going to direct the first three to Dr. Ferew. Just a moment. Great. Okay. So there's three questions and I'll share them with you, Dr. Ferew, all at the same time for ease and let you respond to them. Okay. So the first one is, how do you explain the increase in the positivity rate? Do you have any data? And why is the number of testing cases significantly decreasing in contrast to increased capacity to test? That's the first one. The second, can you please tell us more about the Government Stringency Index and if and how it is used in decision-making relevant to nutrition? And then the third, in relation to COVID-19, you mentioned some misconceptions around consuming food of animal origin. Could you share what these misconceptions are and how they are being addressed? Over to you, Dr. Ferew. I should say, I beg your pardon, that's the first three, and then there's others in our list that have come in for Dr. Sisay. So if you could please keep your answers succinct, it would be greatly appreciated. Thank you.
Thank you. I think in terms of the increase of positivity rates as well as the reduction in the testing, I think what seemed as the reduction in testing is we had the combat of the campaign, which was end of August and September, which raised our capacity. But the whole issues in terms of testing reduction, and which seems as the positivities have increased, is sort of an indirect look at what we are talking. But it also links with the stringency index, as you said, because stringency index is risk openness to governments use or globally is used in 180 countries that will test if you need to open up or you need to close down based on 18 indicators which were developed by Oxford University. So the school closures, travel restrictions locally and internationally, public gatherings and others are the indicators of stringency index. So when these stringency or lockdowns reduce, there is also a lot of poor social distancing and other activities, and also the misconceptions of using face mask and others reduces. So the positivity rate has also increased because of those. But the number we were testing in September and August, which was 4% positivity rate, was because we were testing 20,000 per day, and the low number of positivity rates at that time is more or less the same as what we are getting positive now. So the whole idea is the testing reduced because of capacity in terms of human resources, testing kits, as well as finances throughout the system. But we just started producing the test kits so that would hopefully solve these kind of issues of which looks as positivity rate is increasing. And as I said, the stringency index is a global indicator which is being used. In terms of misconception, I think there are lots of misconception around, which is stated also by Dr. Sisay, was using of the spices, cultural, traditional spices, garlic, and various things was quite high. And also people were being taught to do, stop consuming fruits and vegetables as well as animal source foods. But I think through continuous media communication, we have been trying to address what should be done in terms of consuming what and what people should do, starting from breastfeeding if there is a breastfeeding mother, as well as consuming fruits and vegetables and the various 9 or 10 types of foods which should be consumed by everybody. And also these have been translated and regionally distributed through media so that we could raise consciousness, we should overcome the misconceptions. I'll stop here.
Okay, thanks. Thank you very much. These are questions that I'm sure you could say a lot more on. You could probably deliver a whole entire lecture on them, Dr. Ferew. So thanks just for giving us a short answer just to increase our understanding of some of these complex issues and the situation that you're facing in Ethiopia. I would like to direct a few questions now to Dr. Sisay. Bear with me. Okay, Dr. Sisay, at the moment there are 3 questions for you on funding for nutrition. You referred, if you can link them to COVID-19, that would be great. If you can't, that's fine. But if you can, please do. Number 1, you referred to federal treasury resources for nutrition. Has Seqota had an impact, and what interventions specifically might have been tried and were successful in raising domestic resources for nutrition? Number 2, is the costed woreda-based multi-sectoral nutrition investment for all 40 woredas or just for some? And number 3, how are you managing with the major budget cuts of the PDUs? Over to you.
Thank you, Anne, for the questions. I think for the first one, the key for the investment increase in Seqota Declaration is high-level leadership ownership of the declaration at federal and regional level, as well as the leaders has also conduct a learning journey to the woredas where we are implementing the Seqota Declaration. So engagement of the leadership has been key, especially their excellencies, the ministers. They travel to the woredas to see what is going on, what is working, what is the challenge, and also how they could be part of the solution. I think that has really enabled them to make an investment decision at the cabinet level. So we developed the investment case and they have been able to approve that. So I think the key is engagement and ownership of the highest government leaders who have a power to decide on the budget. The second one, the short answer is the investment plan is for all the woredas. And currently we are also developing the expansion phase, reaching more woredas that will be involved in the coming years. So the investment case is for the 40 woredas. The third question, I didn't get it well. Anne, can you repeat?
Oh, how are you managing budget cuts of the PDUs?
Okay, for the PDU budget cuts, I think what we were doing is, even if there is a budget cut, we are also reprioritizing what to do and also what not to do. So I think whenever you have a budget cut, and also considering the COVID-19 response, you have to reprioritize what to do and what not to do. That is the first thing. The second thing is we are also doing our plans to be COVID responsive. So COVID has also given us an opportunity to raise resources. For instance, recently we have been working with ECSC to generate more resources for the first 1,000-day public movement. So I think utilization of the media has created, more opportunity for us also to generate more resources to reach more communities using media. So it's an opportunity and a challenge, but still we are also, using the COVID-19 responses to generate more funding. Thank you.
Thank you very much. Fantastic. I've got a couple of questions for Dr. Ferew from participants. Dr. Ferew, what did you do differently to provide food to the severe acute malnutrition affected children, given the risks of COVID-19? Was this sustained during the pandemic months? And did you prevent or reverse the expected worsening of severe acute malnutrition cases? And number two, is there any intervention ongoing to provide nutrition or fortify staple food to displaced people in affected region by recent conflict in the country? Over to you.
Thank you. I think the severe acute malnutrition of some cases and the management led by the Ministry of Health is also organized or coordinated by the Disaster Risk Management Coordination Office, which is under the Prime Minister's Office. So we do the usual identification as well as bringing partners together and taking actions in various areas where some cases have increased. It has not increased that much based on over what we have been looking at, seeing in the last few years. And the management was more or less the same and it's being managed. But the problem was getting the resources or the ready-to-use therapeutic for others from various sites was not easy because a lot of flights and other transportation was not easy. So it is being managed well in terms of the coordinated by the Emergency Nutrition Coordination Unit under the Disaster Risk Management Council, which is also covers these areas which you may say the second question covers are where displaced people affected by regional and recent conflicts. It's mainly due to reasons where the intervention is being coordinated by a high-level government sector. It's being supported through staple foods rather than fortified foods, which we don't have in Ethiopia a lot. We haven't started fortifying, but providing nutritious and staple foods is being done for displaced people in affected areas. Over.
Thank you very much. Indeed, you're covering a lot of ground in a pretty short period of time with these questions. Thank you.
Sisay adds.
Question for Girma regarding reproductive health, maternal health, newborn health, child health, adolescent health, young people, and health and nutrition. I didn't read the long acronym. I tried to say it all. Were there any specific gender provisions implemented that could be a model for other countries?
Come again, and
so with regarding what you shared around reproductive health, reproductive, maternal, newborn, child, adolescent, young person, health and nutrition, were there any specific gender considerations, gender provisions, gender equality considerations implemented, especially in light of the pandemic, that could be a good model for other countries, that other countries could learn from?
Well, I would say in general, NI programs are gender responsive. Some of them, like adolescent health and nutrition, it is gender responsive. Some of our intervention like vitamin A supplementation and zinc and ORS for diarrhea management, these are somehow I would categorize them as in Ethiopia as gender sensitive. So maternal newborn health and the nutrition, it is gender responsive. So during this time, what we did exactly is more of COVID response. We have a plan for gender responsive for adolescent girls, but community-based distribution, which we couldn't implement for supply kit. Otherwise, some effective strategies has been used, like home to home distribution of iron folic acid supplementation to make sure that pregnant women are not at risk, because there are specific they are part of the risk groups. I would say this could be considered as gender specific for COVID, but we were considering, we were planning to use adolescent girls promoters to distribute weekly iron folic acid supplementation through community-based approach, which is could not be implemented because of supply. These are what I can say.
Thank you. That's very helpful indeed. Thanks for sharing about those targeted interventions. For Dr. Sisay, you noted some of the challenges with nutrition program coordination, but coordination has been a long-term problem even before COVID-19. Could you give us a quick update on the implementation of the recent nutrition policy, which was intended to improve on the coordination of nutrition programs?
Thank you, Anne. Of course, yeah, coordination has been a long-term problem, but in terms of Seqota Declaration, how we are addressing coordination challenge is by allowing the highest government body to lead the coordination. For instance, for Federal Program Delivery Unit, it is His Excellency's Deputy Prime Minister, and at Regional Program Delivery Unit is Their Excellency's the Regional President. So if the highest authorities are the owner of coordination, I think it will work. That is what we learn from Seqota Declaration, even if the final evaluation is pending. But in terms of the nutrition policy, to translate the nutrition policy, we are currently working on the national nutrition, the food and nutrition strategy. And that strategy has reached at the costing stage, where Seqota Declaration will be also part and parcel of it. So in terms of implementing the policy, we have reached at the food and nutrition strategy development level. But in terms of governance, the policy also provides provision for the establishment of Food and Nutrition Council that is also led by the highest government authority at federal, regional, and lower level, and also the establishment of Feed and Nutrition Agency. So I think if this proclamation is approved, now the issue of coordination will be finally resolved with government-owned and also government-financed coordination body establishment from federal level up to the Warada level. So in terms of the translating the food and nutrition policy, we have achieved the finalization of the proclamation. We are now waiting the cabinets of ministers endorsement that will go back to the parliament for approval. Thank you.
Fantastic. Thank you very much, Dr. Sisay, and thank you all for such engaging questions. I'm loath to say we don't have time for experience sharing, because most people love talking about their experiences. I know I do. Therefore, we're going to close, and I'm going to hand over to Dr. Pendame for closing remarks. Thank you very much, Dr. Pendame.
Sorry, I was trying to unmute myself. I hope you can hear me now. Hello?
Yes,
we can hear you.
Go ahead.
Thank you.
Thank you.
Thanks very much, Anne. First of all, allow me to thank the NTEAM and the TAN team, led by the directors for those two areas, Kefas and Anne, and your fellow colleagues for working hard to make this webinar a success. I would like also I know that the Kenya team, led by Dr. Amare, also worked with the NTEAM and the TAN team to ensure that this webinar takes place. Second, my thanks go to the eminent three presenters that have briefed us about the NTEAM stroke TAN project adaptation work in Ethiopia to address the challenges of COVID pandemic and the lessons learned thereof. Third, I wish to thank the participants. I was interested to know how many participants actually registered and they actually came to the meeting. There were 60 plus participants. As I talk now, there are still 59 connected. So I would like to thank you for your attendance and also the active participation on the discussions. I think you raised the pertinent issues that the presenters were able to follow up to actually give response. It might be that there are still questions that have been not responded to based on the time availability, restrictions. So I would like to ask the organizers to make sure that those questions that have not been responded to can be actually responded to through emails. Fourthly, on behalf of Joel, the President and CEO of Nutrition International, and my EMC colleagues, I would like to recognize the support and collaboration of the donor partners to the NTEAM mechanism and the TAN project. These are namely the UK Aid, Global Affairs Canada, Big Win Philanthropy, and Dangote. I think they have been working with us. Without their grants, we could have not managed to provide strategic TA to governments and institutions seamlessly. To the consultants who were engaged to support the process, I would like to thank you for your technical expertise and collaborating with them, the NTEAM and the TAN project in ensuring that the assignments that you were given, prioritized by our partners, you were able to timely actually deliver the outputs. Madam Moderator, I hope the many outcomes of this webinar session will be shared by the participants, as well as NIEMC team sooner than later, while we are still thinking about the webinar. It is now my honor to declare the webinar closed, and I wish you to continue all the best and continue to keep safe. Thank you very much.
Thank you, Richard, very much indeed. You've given us our tasks. We look forward and commit to sharing the presentation and responding to questions that we didn't have a chance to respond to today. So we commit to doing that very, very soon indeed. Thank you very much for joining us. I hope this webinar has served to connect the experiences shared by our panelists with how you and your organization are responding to COVID-19 and adapting in the face of it. So thank you very much, and we hope to see you next time.